Okay. Good morning. So today we'll be discussing about classification of dementia and Alzheimer's disease and pharmacological management of dementia. Okay. So I'm Dr. Rohit Balakrishnan, Senior Resident, Department of Psychiatry, Sri Lakshmi Narayana Institute of Medical Sciences, Pondicherry, affiliated to Bharat University, Chennai. So this slide shows the basic classification of dementia. So it is classified under various headings. As you can see, under degenerative type, neurological diseases, vascular diseases, endocrine, nutritional. So basically, according to their causative factors, it is being differentiated. So degenerative diseases, as we all know, Alzheimer's disease is the most common, and dementia with Lewy bodies, frontotemporal dementia, Parkinson's disease, Huntington's, corticobasal syndrome are a few examples. So under neurological diseases, like neurological causes like multiple sclerosis, NPH, brain tumor, primary or metastatic are some of the causes. And vascular, any infarction to the brain or any hemodynamic insufficiencies can also cause. So as we all know, hypothyroidism, hypercalcemia, hyperglycemia can all lead to dementias. And nutritional deficiencies, especially vitamin B12 deficiencies, thiamine and niacin deficiencies can lead to dementia. Also, metabolic causes like hepatic insufficiency, renal insufficiency, Wilson's disease, metachromatic leukodystrophy, neuroacanthosis can cause. And traumatic causes subdural chronic traumatic encephalopathy or dementia pugilistica. And also chronic exposure to alcohol, heavy metals, radiation can lead to dementias. And anticholinergic medications also, chronic exposure. And also infectious diseases like HIV, neurosyphilis, cryptococcus can lead to the dementias. So about focusing now on Alzheimer's dementia. So the rest of our presentation, we will follow this format. So we'll start off with introduction epidemiology. We'll go into the pathology, the etiological factors, also the clinical features, diagnostic criteria, DSM diagnostic criteria, and also the laboratory examination, what laboratory tests we should do in a patient with dementia. And also a small note on pharmacological management and course and prognosis. So introduction. So as I told earlier, Alzheimer's disease is the most common dementia. It accounts to more than 2/3 of all dementias. So the second most common will be vascular dementias. And the third, as of now, is frontotemporal dementias. So it is broadly classified into early onset and late onset. And according to ICD-10 criteria, 65, the age 65 is the age that is set to differentiate between early and late onset. So as we all know, dementias are classified also according to their course, like how their onset and course. So in Alzheimer's disease, it follows a characteristic pattern. It is insidious in onset and it has a gradually deteriorating course. And it has a specific associated with specific neuropathological changes, which we'll be seeing in detail in the coming slides. And Alois Alzheimer's, he is the first person, he is the one who described this disease in 1906. So as we all know, there is a high prevalence in older age and advancing population. So epidemiology. So the incidence of Alzheimer's disease increases with age. So it is only 0.5% per year from age 65 to 69, and post 65 it is known to double. So 1% from 70 to 75, and 2% from 75 to 79, and 3% from 80 to 85. And post 85, there is a spike in the incidence. Around 8% per year has been reported. So coming on to the pathology. So basically, Alzheimer's disease will lead to the shrinkage of the brain size. So initially, in the earlier stages of the disease, it might appear normal, or there might be atrophy confined only to the hippocampus. As the cerebral cortex shrinks, there will be an increase in the ventricular size. And obviously, the first ventricle to dilate will be the inferior horn of the lateral ventricle because of the atrophy in the hippocampus and the entorhinal cortex. So gradually, this atrophy will distribute to the entire brain, and it will lead to a generalized atrophy of the entire brain, like in temporal, parietal, and frontal lobes. So microscopically, we have amyloid plaques and neurofibrillary tangles. They are the characteristic lesions, but they are not specific because they are also seen in other dementias, like in Lewy body dementias and frontotemporal dementias. So, what are amyloid plaques? They are composed of insoluble deposits of fibrillar A beta. So, A beta is an amyloid plaque A beta. So, there will be an abnormal deposition of A beta. So, if you see in this picture, so at the center there is this amyloid plaque. Okay, so surrounding the amyloid plaque, there will be a lot of microglial cells, reactive astrocytes, and dystrophic neurocytes. So this so something is happening, so there we have all our microglia and astrocytes activated. So all these things will lead to dystrophic neurocytes. Okay, so these amyloid plaques, they are found first throughout the neocortex, followed by the entorhinal cortex and the hippocampus, and then the subcortical areas. So this is in contrast with what we had told earlier in the microscopic changes, where the shrinkage is first seen in the entorhinal cortex, and then it spreads through the other regions. But now, in the case of amyloid plaques, it is seen first throughout the neocortex, and finally it will end up in the entorhinal cortex and hippocampal area, and then it will go on to the subcortical regions. Okay, so amyloid plaques are the defining lesion of Alzheimer's disease, but it is not specific to it. So microscopic pathology continuing. Next is next characteristic lesion are the neurofibrillary tangles. So they are basically intracellular inclusion bodies. Okay, so they are composed of aggregates of hyperphosphorylated microtubule associated protein. So that is the MAPT. So they are first found in the entorhinal cortex. That is in contrast with whatever we had talked earlier about the amyloid plaques. So this is first found in the entorhinal cortex and spread from there to the hippocampus, the lateral temporal lobe, and more widely through the neocortex. Okay. So these are two other characteristic lesions, but there are also abnormal aggregation of alpha synuclei. So it is present in almost 60% of the cases. So what are alpha synuclei? So they are like thread-like deposits. Especially alpha synuclein deposition is more commonly seen in Parkinson's disease. Okay, that is a Lewy body dementia. So in that, it is seen as an intraneuronal inclusions. They are called as Lewy bodies. So it can also be seen in Alzheimer's disease, but to a lesser extent. So the other thing is the TDP43 proteinopathy that is seen in around 19 to 57% of the cases. And there is also marked neuronal loss, which is more markedly present, as we had told earlier, in the entorhinal cortex and hippocampus, because that is the first place where it has begun. So the neuronal loss will also obviously be more over there. And as we all know, there is a loss of cholinergic neurons in the nucleus baseless. That is that is also leading to a lot of symptoms like memory deficits, amnesias. So that is caused by this loss of cholinergic neurons, especially the nucleus baseless. And also there is a loss of brainstem noradrenergic and serotonergic neurons. So other pathology that are seen are granulovacular degeneration and the presence of bodies, which are most commonly affecting pyramidal neurons in the hippocampus. They also might be found. Okay, now going on to the genetics. So we will be covering about, etiology. So we will be covering about the genetics of it and about amyloid B protein and about the synapse loss and also the risk factors and the protective factors. So genetics. For the early onset Alzheimer's, that is Alzheimer's disease, which is present in less than 65 years. Okay, so it is quite rare. It is seen in only 5 per 1 lakh people. Its incidence is quite low. But if it is present, the main causative factors, genetic factors, are the 3 genes. That is the APP gene, the presenilin 1 gene, and the presenilin 2 gene. Okay, so the presenilin 2 is quite rare. The more commonly seen are the presenilin 1 mutations. So the APP gene is located on the chromosome 21. There are around 30 mutations that are reported in APP gene. So in presenilin 1 mutation, it is seen in chromosome 14, and presenilin 2 is more commonly seen in chromosome 1. Okay. So the APP mutations and PS1, that is the presenilin 1 mutations, appear to act as an autosomal dominant traits with nearly complete penetrance. So once it is present, it will be carried over to the next generation. So the late onset, the main player is the apolipoprotein E. This is people having an Alzheimer's disease late onset have found carrying the epsilon 4 allele in both the familial and the sporadic cases. That is ApoE4. ApoE4, the epsilon 4 allele is in ApoE4. So what is actually an allele? So we all know that all the genes are a part of the chromosome that actually replicates. So the similar copy, there are 2 copies of one particular gene. So each copy, it is called as an allele. So a single copy of the ApoE4 allele confers an approximately 2 to 4-fold increased risk, while 2 ApoE4 alleles increases the risk by approximately 4 to 8-fold. So the risk is attenuated in older individuals and in African American and Hispanic individuals, whereas the risk confirmed by ApoE4 may be increased in individuals with Japanese ethnicity, those who come from the Japanese background. So it is generally estimated that ApoE4 accounts for up to 50% of the genetic contribution to the late onset Alzheimer's disease. Okay. So there are also other genes that are that can cause late onset Alzheimer's disease. So that has been listed here. But the main player is the apolipoprotein E4. But I would just like to read out the other genes that is listed here, like CR1, BIN1, CLU, PICALM, BICAM, MS4AA or MS4A6, CD2AP, CD33, EPHA1, ABCA7, HLA-DRB5 or DRB1, SORL1, PTK2B, SLC2A, 2A4, 24A4, sorry, or RIN3, INPP5D, MEF2C, NME8, ZCWPW1, and etc. Okay. So about the amyloid B protein and synapse loss. So APP protein, that is the precursor to the amyloid beta plaque that is seen there. So it is actually originally cleaned by alpha, beta, and gamma secretase. So cleavage by an alpha secretase that will yield a non-toxic peptide. But if this APP protein is cleaved by either an alpha or beta or a gamma secretase, that generates an insoluble protein called A beta that has around 42 amino acids. So this A beta protein deposition is the basic in the Alzheimer's disease process. So there is evidence indicating that self-aggregation of A beta into soluble low N oligomers is a primary source of synaptotoxicity in Alzheimer's disease. So A beta itself is causing synaptotoxicity. So human studies indicate that cortical synapse loss is an early pathological event, and that cognitive impairments and synapse loss correlate more strongly with soluble A beta, even in subjects with early disease. Okay. So A beta may lead to synapse loss and neuronal death via downstream mechanism. So this A beta is contributes to the neuronal cell death wherever it is being deposited, and also it contributes to the hyperphosphorylation of the microtubule associated protein tau, so which enhances aggregation. So the overproduction and aggregation of MAPT have been shown to cause synapse loss and neuronal death. So A beta contributes to the aggregation of the it contributes to the hypophosphorylation of the microtubules. So generally, microtubule associated micro protein are not like deposited. So once it gets hyperphosphorylated, that hyperphosphorylation which leads to its aggregation. Okay, so both this A beta protein and neurofibrillary tangles. So both of them together they cause synapse loss and neuronal death. So plaques themselves form substantial space-occupying lesion in the cortex of the individuals with Alzheimer's disease and serve as a site for inflammatory responses. So both these mechanical and inflammatory process may further contribute to synapse loss and neuronal death. Just move this. Risk and protective factors. As we all know, age is the most important risk factor. Okay, so the doubling the risk every year, doubling. As I had mentioned earlier, post 65 years old, the risk is doubled. Okay, so the most important, the most constantly found risk factor is the age and education. So education, as we all know, Alzheimer's disease are more commonly seen in patients with less education. So studies have found that a protective effect of education exists there because there is higher levels of cognitive reserve may be able to utilize other alternative neural networks as levels of pathology increase, thus compensating for the disease burden up to a point. So also not only with the patients and also the education level of the caretakers are also important because that can lead to the disease burden in the patient and the caregiver burden and with the family members also. So estrogen hormone replacement therapy after menopause, they have also shown to reduce the risk of Alzheimer's disease. However, the results from the largest RCTs of HR therapy indicated no prevention of cognitive decline with estrogen replacement therapy in women aged 65 or older, and evidence of increased incidence of dementia in those women receiving combined estrogen progesterone replacement therapy. So there is a mixed view on the the role of estrogen in preventing Alzheimer's disease. So head trauma, as we all know, any traumatic brain injury is associated with an increased risk of developing Alzheimer's disease. So there is evidence that head trauma can lead to the overexpression of APP. So increasing inflammatory mediators and cause A beta deposition in the brain and thus evolving into an Alzheimer's disease. Okay. So inflammation. So NSAIDs we all know prevents inflammation. So there is a recent review evaluating the role of NSAIDs in the prevention of dementia. So it showed an association between NSAID use and reduced dementia risk. However, the one RCT that was included showed no effect of NSAIDs use on the prevention of dementia. So this also there is a debate on this topic. So moving on to the clinical features. So we all know how Alzheimer's disease presents. So it is not just decline in memory, but also a general functioning of an individual. Obviously, so the patient will present initially as an MCI. So what is an MCI? Is mild cognitive impairment. So when the patient has a mild cognitive impairment, he understands that he has some issue with him, some issue with his brain, that he is not able to function as he could earlier. Might be he can have some memory disturbances or he can have some disturbances at his workplace. He's not able to concentrate as earlier. His attention span might have gone. So some issue with his brain he can feel that is affecting his work and his day-to-day life. I mean, he feels that he finds it. He finds that there is some issue that he is dealing with, but that should not affect his day-to-day life. So when it doesn't affect his functioning, then it can be categorized as an MCI. So people with MCI gradually progress into dementia, and that depends on what type of MCI the patient has. So once in the dementia onset, so now we are talking about Alzheimer's, there will be an insidious onset and gradually deterioration with the patient's day-to-day activities. So like day-to-day living. So it will end up like patient is not able to do his work at his job properly, and also day-to-day affairs that does at home. And it might reach a stage that his even the self-care will be impaired. He cannot dress, he cannot button himself, he cannot have food, he cannot feed himself, and his sleep cycles, everything gets disturbed, and he gets irritable. He doesn't know what is happening around, and he forgets things. He might urinate inside his home only, and he might cause a lot of trouble to others because of all these things, and he might end up being totally dependent. So that is the basic gist of how an Alzheimer's disease would present. So now let's focus mostly on the cognitive impairment, and that includes amnesia, aphasia, apraxia, and agnosia. Now just a little information on what these are. So amnesia, as we know, is a like a memory deficit, and it can happen as an episodic, semantic, or a visuospatial defect also. So episodic memory is whatever things that happen in our life, like what did we have yesterday, so what we actually did yesterday, so what food we had. So patient will have that episodic memory deficits of whatever was happening in his life. And semantic memory is basically the factual knowledge, whatever who is the Prime Minister of India, who is the President of India, so how many states are there. So that goes into the semantic part. So in Alzheimer's disease, there will be initially a deficit in the immediate and the recent memory, and long-term memory is what might be retained until late stages wherein we can lose that also. So in aphasia, like patient might have word finding difficulties, and so the earliest sign is a word finding difficulty, and later on it might lead to perseverations, echolalias, decreased fluency, and non-speech verbalizations. Apraxias, difficulty with complex motor tasks, even though a patient can understand what is the task that is being told. Okay. And agnosia, failure to correctly interpret a sensory input. So prosopagnosia is inability to identify faces, who it is, the familiar faces. Okay. So executive functioning. So executive functioning is basically a functioning of the frontal lobe. So it actually helps us to plan and program whatever is happening in our day-to-day life activities. So there are a lot of executive functioning tests that we can use to detect, like a stroke test, set shifting test, etc. Tower of London. So these are all the many executive functioning tests that use. So to plan executive function is generally to plan, program, and do a certain set of instructions or to set a task. So that is called as an executive function. So all this will lead to functioning impairment. So there will be initially difficulty performing instrumental activities of daily living, like laundry, shopping, housekeeping, transportation. Later on, as I had told earlier, when the basic activities of the daily living are affected, like dressing, bathing, grooming, feeding. Okay, and on top of this, there can be BS, behavioral and psychological symptoms of skills, that is the neuropsychiatric manifestations where B come in. So it can be even psychotic mode and activity related. So patient might have paranoid or delusional ideation if it occurs with any like any peripheral sensory reduction, like in Charles Bonnet syndrome. So there can be hallucinations also, like most common are visual hallucinations, and there can be misidentification syndromes also. So mood. Many people might be anxious as they are not knowing. So almost most common found is anxiety. More than 50% of it is anxiety. So because they are not knowing what is going around, they some people might know that can understand their deficits. So all these can lead to anxiety and also depression. So 10 to 25% of them are found to have depression, and mania also less than 5%. So other disturbances include apathy, agitation, wandering, aggregation, circadian rhythm disturbances. So these are all the other activity related things. So this is the ICD-10 diagnostic criteria. So the following features are essential for a definitive diagnosis. So presence of dementia, as told earlier. So what are all the symptoms of cognitive impairment that the patient is facing? The patient might be impaired in the judgment, all those things might be impaired. So the presence of dementia must be there. So to categorize it as Alzheimer's dementia, that it should be of an insidious onset with slow deterioration. So there is also an absence of clinical evidence or findings from special investigations to suggest that the mental state may be due to other systemic or brain diseases, which can induce a dementia, as we had discussed in our second slide about the various causes of dementia. So we should rule out hypothyroidism, hypercalcemia, vitamin B12 deficiency, niacin deficiency, and also infective diseases like HIV, neurosyphilis, normal pressure, hydrocephalus. And also there should be an absence of a sudden apoplectic onset or of neurological signs of focal damage. So in this case, wherein we should diagnose it as a vascular dementia. According to this ICD coding, the dementia of Alzheimer's with early onset, late onset, and atypical or mixed type, and it is unspecified. The DSM-5 criteria. So there's a significant cognitive decline from a previous level of functioning in one or more cognitive domains, as evidenced by concern from the individual, the clinician, or another knowledgeable informant that there has been significant cognitive decline, significant impairment in cognitive performance, ideally seen on standardized neuropsychological testing. Okay, neuropsychological testing, or if that is not available, another clinical assessment. Okay, so cognitive decline interferes in day-to-day activities. So first point is basically there should be a cognitive decline from the previous level of functioning. So that concern should be given by the individual, the clinician, or another knowledgeable informant that there has been a significant cognitive decline, and also we should have a testing, and we should have a clinical assessment wherein that cognitive decline is confirmed. And so it should also interfere with day-to-day activities. And the deficits do not occur exclusively during the course of a delirium. So we should differentiate this from encephalopathy. Okay, so the deficits cannot be explained by another mental disorder. So that that should be like continued with the specifiers, like without behavioral disturbances, with behavioral disturbances, and also we should need to grade the severity, mild, moderate, or severe. Okay. Okay. So this is what I had been discussing earlier about the MCI, mild neurocognitive disorder. So there should be an evidence of modest cognitive decline from the previous level of performance in one or more cognitive domains as given like this. So that should be based on the concern of individual or an informant or a clinician that has been a mild decline in cognition should be there. And also there should be a modest impairment in cognitive performance, preferably documented by a standardized neuropsychological testing or in its absence and the quantified clinical assessment. So that is like in previous. So that when it does not interfere with the capacity for independence in everyday activities, then we can term it as a MCI, mild neurocognitive disorder. Okay. So the other the other things are the same as Alzheimer's disease. So diagnostic criteria for major or mild neurocognitive disorder due to Alzheimer's disease. So now we know the DSM-5 criteria for what like MCI is and what for major neurocognitive disorder should be. Now, if it is for Alzheimer's, then the criteria A is for major or mild. So the presence of dementia is there. So there should be, second point is there should be insidious onset and gradual progression of impairment in one or more cognitive domains. Okay, so the third will be criteria are met for either for probable or possible Alzheimer's disease as follows. So for probable Alzheimer's disease is diagnosed if either of the following is present. Otherwise, possible Alzheimer's should be diagnosed. So evidence of a causative Alzheimer's disease genetic mutation from a family history or genetic testing. So all three of the following. So that is one. So there should be a evidence. Okay. Or there should be clear evidence of decline in memory and learning and at least one other cognitive domain. Okay. steadily progressive gradual decline in cognition without extended plateaus, and no evidence of mixed etiologies. Okay. So this is how about the mild neurocognitive disorders. So the laboratory examination, what is the testings that we will do in a patient with Alzheimer's? So first, as we all know, is an MRI or a CT. So preferably it is an MRI. So what can we find is a significant atrophy in the hippocampus and related structures, the mesial temporal lobe. So because that is where the first reduction in the mass happens, and cortical atrophy, the frontal and the temporal neocortex. So several agents for PET scanning, amyloid imaging has recently been approved for use. The absence of trace or retention during PET amyloid imaging indicates that dementia is unlikely to be due to Alzheimer's disease. And also there is a decrease in CSF levels of A beta, which is supportive of the diagnosis of Alzheimer's disease. There should be a decreased CSF levels of 42 amino acid species of A beta. Okay. So the use of a genetic marker, ApoE4, is a diagnostic or predictor. So first is a scanning thing, then CSF we take, wherein which we find that there is decreased levels of A beta. Okay, A beta 1 to 42, and the use of genetic marker, genetic testing, ApoE4. Course and prognosis. So the first lasting for 2 to 3 years is characterized by, that's the first stage, by failing memory, muddled insufficiency of a task of everyday life, and spatial disorientation. So the second stage brings more rapid progress of intellectual and personality deterioration, and focal symptoms appear like dysphasia, apraxia, agnosia, calculus is common here. So the terminal stage is an apathetic dementia. Patient becomes bedridden and doubly incontinent. Here, sometimes spastic hemiparesis or severe striatal rigidity or tremors may develop. So patients will often succumb to pneumonia or other infections. That is the medical complications of dementia. So the most consistent finding of many studies is that worse the cognitive state at presentation, worse the rate of subsequent decline, and this holds true even in early stages of Alzheimer's disease and prodromal Alzheimer's disease. Okay. So the aphasia and apraxia have been found to be predictors of rapid decline and mortality. Okay. So something in brief about the pharmacological management. So on the screen are the various drugs that we use in dementia. So donepezil, rivastigmine, galantamine, they are acetylcholinesterase inhibitors, and memantine is an NMDA receptor antagonist. So usually at first we start with donepezil. So for mild to moderate dementias, we start with donepezil. So we give them start them at 5 mg and can increase up to 10 mg. So when there is a severe dementia, moderate to severe dementia, and also when dementia is associated with behavioral disturbances, then we start them with the NMDA receptor antagonist, memantine. So memantine's dosage are also similar to that of donepezil. That is 5 mg initially, and then we can increase that up to 10 mg. So the more the more common side effects of donepezil includes diarrhea, nausea, headache. Rivastigmine includes anorexia, dizziness, nausea, vomiting, diarrhea, similar. And with the galantamine also, it is nausea and vomiting. With memantine, there is drug hypersensitivity, somnolence, dizziness, and balance disorders. So this is what I was talking about. So donepezil, the starting dose will be 5 mg. So there will be titration of 5 mg after 4 to 6 weeks. So the effective dose is 5 to 10 mg. So the maximum dose is 23 mg. That is a delayed, extended extended released version of donepezil. And NMDA receptor antagonist, memantine, is 5 mg. That is the starting dose, and which we increase by 5 mg weekly divided. So the effective dose will be 20 mg divided weekly. Okay. So for pharmacological management of the neuropsychiatric manifestations, so more commonly we use atypical antipsychotics like risperidone, quetiapine, olanzapine, and aripiprazole. So it is mainly used for agitation and psychosis. So as we all know, the major side effects include the increased risk of metabolic syndrome, weight gain, diabetes mellitus, hyperlipidemia, etc. So for short-term control of acute behavior, we can use benzodiazepines like short-acting ones like lorazepam or oxazepam. So the major problem is the disinhibition. So there might be increase in the aggravation of the patient. So carbamazepine also there will be a modest benefit in agitation, and the major side effect is sedation that can also lead to sleep. That can be use also that can for which carbamazepine is done. So if there is any presence of depressive symptoms, then SSRIs can be preferred. So SSRIs is the drug of choice in elderly, antidepressant drug of choice in elderly. So that, as we all know, the major side effect would be sexual dysfunction, nausea, diarrhea, vomiting, and anorexia. Okay. So other agents that can be used include NSAIDs inhibitors, as some studies have reported that anti-inflammatory agents reduces the inflammation and can cause some improvement in Alzheimer's disease, and also statins, HMG-CoA reductase inhibitors. So main mechanism of action is that it's cholesterol depletion strongly inhibits beta amyloid secretion in the APP process. So, but the evidence is insufficient. And there are also secretase inhibitors, metal chelators, and vaccines that can. So vaccines are still on trial, and these are all under trial. Metal chelators basically dissolve amyloid plaques. Copper and zinc are implicated in the formation of amyloid plaques. It's based on that copper and zinc are implicated. So metal chelators might decrease the presence of amyloid plaques. So these are all ongoing investigations. And certain antibiotics, tau kinase inhibitors, tau aggregators, estrogens, curcumin, diamabol, and have all found to be increased useful in this. So that ends my presentation for like my teaching this thing for today. So these are my references. Okay, thank you.